Good afternoon. I'm Cynthia Charles, Vice President of Public Relations for the North Carolina Healthcare Association. Welcome to our town hall conversation about mental health issues in North Carolina. We have people joining today on Zoom and on Facebook. We're glad you're here. At the North Carolina Healthcare Association, we believe that mental health is equally as important as all other aspects of a person's health. Our vision is for a North Carolina where high quality healthcare is equitable and accessible for all. Before we start, here are a couple things to know. During the program, all lines will be muted. If you have any technical issues, use the question pane to send a note to John Rao, the event organizer, and he will assist you. Questions can be submitted anytime using the question or chat pane on the bottom of your screen. You can also submit questions on the North Carolina Healthcare Association Facebook page. Please know that our audience today has already submitted dozens of questions for our panel. We will not have time to get to them all, but we'll get to as many as we can. We'll also try to get to some live questions. So if you submit a question, be patient. We see you and we'll try to work it in. We have a wonderful panel today, and they're very impressive, including representatives from the North Carolina Psychiatric Association, the North Carolina Chamber, UNC Health, Novant Health, and Cone Health, and of course our moderator, Dr. Nisha Mehta. I'd like to introduce her to you. Dr. Mehta is a physician in the Charlotte area. She's a writer and speaker on many health and medical topics, including physician work-life balance, which is an important part of mental health. Welcome, Dr. Mehta.
Thank you, Cynthia, for that kind introduction. We have a lot to talk about today, so I want to dive right in. Mental health and physical health are closely connected and critically important. More than 450,000 adults and young adults in North Carolina have a serious mental illness, and rates of depression, anxiety, and other disorders continue to rise, in part due to the COVID-19 pandemic. Hospitals across the state are innovating to bring high-quality mental health care to more North Carolinians. Many areas face shortages in behavioral health specialists like psychiatrists, as well as shortages in inpatient mental health beds for those in crisis. Let's set the stage for this by talking about the current crisis and historical background. COVID-19 has made an already critical need for mental health services even more urgent. At a high level, Gary, can you talk about what you're hearing from your chamber members or about the impact of the crisis on workers?
Well, thank you, Dr. Mehta, and thanks to NCHA and for the folks here today. First of all, for all you have done for all of our citizens, our employers, over the last year and a half, but for your entire careers, it is appreciated with it. And we are hearing from employers, like we hear very often, is their people are their priority. So when it comes to the physical, the mental, and the financial health of their employers, it's critically important to them that all of those are in balance and that they're living healthy lives. The pandemic, as you all know, has really thrust people into an environment that none of us expected, which produced all kinds of different stressors and stigmas. And employees are now coming back to work in whatever measure the employer and the government feels appropriate, with an entirely different set of circumstances than they left the workplace with, whether it's childcare issues, whether it's worrying about parents that they're caring for, whether they're worried about can they do their job and actually take care of their family at the same time, financial pressures. So the stressors we're hearing about is our workforce, our people are coming back differently than when they left the pandemic. And all of those issues require support, education, most of all listening, and spending some time listening to what's going on and be creating safe spaces for their workforce, for their people. So we're getting a great deal of feedback now as the primary issue is how's our talent doing? How are our people doing? And within that talent piece is, okay, the mental health issues, challenges, stressors in their lives are at a level that they've not seen in their workforces. And, you know, there are always underlying and behavioral mental health issues in our society, and that have been going on for a while. The pandemic, for all of us, regardless of where we are in a corporation or where we are in our careers, has placed us all in new places. So it's a top priority. Talent is the issue we hear about 1, 2, and 3. And within that, it's about the mental and physical health of the folks that are coming back into the workforce now as they come through a year of Zoom, a year of working and balancing and dogs barking in the background when they're on there, or trying to find ways to see people they haven't seen in a year and a half or 2 years because of the pandemic. So we're excited to partner and collaborate with our health systems, our healthcare providers, and talk about ways that we could even further enhance the resources that are available to folks as they come back.
Absolutely. I think this pandemic has really just led to unprecedented levels of stress that have really exacerbated existing issues. Does anybody else want to talk about the impact of mental health issues and moral distress in healthcare workers and some things that their systems are doing to address that?
At UNC, we have a very elaborate well-being program that's system-wide for all of our employees. And we started that before COVID, but quickly realized that we had to expand those resources. And that's what we're seeing, that employees need the resources even more than the patients at the hospital, because they're dealing with workforce shortages, dealing with, with death, just dealing with so much stress. And we really need to make sure that we're supporting the workforce as well. And another shift that we're really seeing is a generational one. I mean, pretty much most baby boomers were able to, retire as soon as the pandemic hit. A lot of them did. Some that maybe were planning on working longer changed their minds once the workforce got so much more stressful. So we're seeing a real shift to the majority of the workforce now are going to be Generation Z, and they're going to respond to interventions much more differently than other generations before. So we're doing some things, for example, using apps, well-being apps, so that people can check in how they're doing. And in the background, we're monitoring. And if we're seeing that folks are really not doing well, we know how to target interventions to help groups or individuals.
We're doing similar things in Novant Health as well, Barbara Ann and Nisha. We have an emotional health advocacy team that is really partners helping partners. It started with our physicians, but we've then ramped it out to all of our healthcare providers. And it's really a way to support one another and have a very robust resiliency program. And to Barbara Ann's point, we have seen a real generational shift as well. The nurses in our ICU are 20-somethings. They're the folks that are at the front lines. And our ICU have turned into really hospices that still have code status. Those nurses are not used to working in that type of environment, and we're really seeing it take its toll. And we've worked with those digital apps as well, Ginger and others, that really help us keep our pulse on our patient or on our team members to make sure that they're not in trouble.
So we're doing something very similar, but we looked at it at a total, how do you look at the mind and body as one entity? What are the tools you can use for reflection? What else do we need for not only our employees, their families, our first responders, the people who are in the ERs? What's the changes we need to do to make sure when we talk about we're right here with you, we need to be right here with everyone, including their families. I think that's the key to success when you look at community, that if you're not including the families and the stresses which are getting people, stressed out with COVID, you're not addressing all this. And I also think it's not one size that fits all. So we've got a lot of apps. We have We Care, which is for suicide prevention. And of course, you've got the depression. But what else? Looking at nutrition, relaxation techniques, self-reflection toolkits, because I think it's important to remember that you can't have one thing that's going to help everyone. So what are the different things you can put together as a healthcare system, not only to help your employees, their families, and also the people in the community who are the first responders?
Absolutely. I think it's so important to take what we can off of people's plates. I think there's just so much on people's plates right now on so many different levels, and the level of fatigue and compassion fatigue and just jadedness after, I think we're all a little bit, we've aged a little bit over the past year and a half. And I think addressing that is really, really important. What other trends are you seeing, not necessarily just amongst healthcare workers, but amongst adults, children, and teens, and other types of workers?
I think one of the things that we're seeing that is particularly important and interesting is that we're learning more about the inter-family reaction between parents and their children and siblings, and what the stressors are of not seeing each other. We continue to learn more about that babies that have been born during the time or grandparents haven't been able to see them. So the stressors too, we're hearing a lot about how some people are approaching the pandemic and how, as was alluded to, the generations are approaching the pandemic different. Every community is different. Businesses within those communities are different, depending on what sector they are and what the nature and culture of the organization is. So we're hearing a whole lot about, and to the point, one size doesn't fit all, and the importance of communication, because even within a business or within a family and with a community, things are very, very different. And so the questions, concerns, the interests in getting help are so varied, very, very, very different.
Absolutely. I'd like to talk about some of the historical factors behind the mental health care crisis in North Carolina. Over the last few decades, state institutions have closed and mental health has shifted to community organizations. How did this process impact the mental health system that we have today? Robin, would you be able to start?
Sure, I'm happy to. And although I should give the caveat, my husband says I start stories with the Pilgrims got off at Plymouth Rock, and mental health system reform in North Carolina has been taking place for more than 20 years. And when it first started in 2000, the state embarked on a really ambitious effort to close state hospital beds so that the state could put more money into clinics, into community services. And they also moved to privatize the system so that there would be more provider agencies who could care for the Medicaid population and folks who had no insurance. And it was a really noble ambition, and we could go hours with just this part of the conversation. But the upshot that's important for this discussion in this setting today is that in the olden days, everybody knew where the mental health center was in your community, in your city, or in your region. And the public and law enforcement knew when to go to the hospital emergency room, but also when and where to go to the mental health emergency room. But in a privatized system, when we moved from the mental health center, and different providers were providing services across your county or your area, providers would change their leases and move to different office spaces. They might brand their clinics with a nice marketing friendly name that wasn't like the mental health center. And I think people just didn't quite know where to go or how to access services. And now the other part is that we never funded the outpatient service system the way that we promised back in the early 2000s. And lobbyists for the alcohol, beer, and wine industries killed the alcohol tax that had been introduced around that same time that would have put an additional $100 million into our system to fund community services. So that was missing. And then we also never quite got the funding from closing the hospital beds. It never quite made it to community services. And there is always going to be a need for the hospital beds. So another issue that's kind of coming up is that, just in the last few years, the last 3 or 4, we haven't had a state budget. We haven't passed a state budget. And what that means is they've been passing little micro budgets that haven't adequately funded the mental health system. And so the dollars that have been promised to fund innovative preventive kinds of services kept getting cut. And so that's kind of how we've gotten to the point where we are today, is that this has been going on for a good 10 plus years with reform, that folks didn't know where to go. So they wound up in the hospital emergency departments. And that became particularly a crisis with COVID.
Absolutely. I guess a really interesting question to maybe go off of from there would be, if you had the power to change one thing to improve the current mental health care system in North Carolina, what would that be? I'd love to hear everyone's thoughts.
Medicaid expansion.
You could either expand on that, or if somebody else wants to chime in.
I would say expansion of crisis services. The reason so many folks are ending up in EDs is because they're in crisis, they have nowhere to go. So we really need to focus our energy on prevention and on having other access to services in other places so that the ED doesn't have to be used as a last resort.
So I agree. I feel that we need to integrate services. So, prevention starts when you change the concept of what people think about mental health. As long as you have stigma, we should prevent having a crisis. So how do you integrate behavioral health and physical health? Mind and body is not separate. What do we need to do different in our communities in terms of education with our providers, primary care physicians who are not comfortable with behavioral health, early detection and treatment? And I think that's how you're going to change healthcare, because till we keep it siloed, physical and mental, it's never going to change.
Yeah, I would add that there's a lot of good that has been going on for a long time, and we've not done a good job collaborating with the healthcare community and the non-healthcare community, my members and the business community, on telling people what's working and what's good in the communities, and sharing best practices in a way that says, I want to do that. How do I do that? How do I begin to integrate care? There's good stuff going on in the systems and with private practices and individual employers, but the broader group of employers that are not in the healthcare space are not aware of it.
Absolutely. That's definitely something we talk about a lot here, about taking a conversation, right? And innovation, and all of that requires having the conversation. Let's move on to opportunities for growth. I think that's a good sort of bridge to that. One of the major issues in mental and behavioral health care is a lack of specialty caregivers like psychiatrists, therapists, and counselors. Paula, Novant Health serves communities in many different parts of the states, including in several rural areas. What's behind these shortages, and how are they affecting those rural communities?
These shortages are not new. And in fact, North Carolina back in 1975 established the provider recruitment from the Office of Rural Health Placement Services. And as of January 21, 94 out of our 100 counties were seen as having a critical shortage of psychiatrists, 94 out of 100. So we know that this is not a new issue. And it really comes down to one of geography, right? Psychiatrists choose to live in areas that are more cosmopolitan. And it's not only a problem for psychiatrists, it's also a problem for these rural areas finding dentists and other primary care providers. So one of the innovative things that has come out of COVID is really being able to expand access to these communities through the use of telepsych. Now, of course, with telepsych, you also need to have that intranet infrastructure. And we found even when we were doing virtual schools that a lot of the kids didn't have intranet. They were sitting outside the parking lot in McDonald's to access that service. And so we need to look at expanding that as a public service, public utility. And then we could hopefully be able to use our talent that are more in the urban areas to help support the rural areas.
Absolutely. Barbara Ann, can you share the academic perspective from UNC?
Absolutely. So to support a lot of what Paula just said, across all of mental health professions, it's always unfortunately had, I think because of the stigma related to it, not been the most glamorous area or the top pick for nurses even. Like they want to work in surgery, they want to work in oncology, or cardiology, not necessarily in psychiatry. So there's been a shortage across the board. But on a positive note, what we're seeing is that actually last year, more med students applied for a psychiatry residence than we've ever seen in history before. So we have hope that conversations like this are really going to help to continue to break down the stigma and make more people, want to step up and help. It's normalizing, like everyone hurts and we need help, and it's not something to hide around. And the other piece is having access to the training ground. So, at UNC, it is academic. So we have everybody and everything that you can think about. We even have one of the country's only pastoral care residencies that are embedded in mental health. So we're trying to train everyone that we can. And again, to support what Paula just said, it's virtual care all the way, because when we are interviewing the different students that want to come here and work in psychiatry, and we ask about where they want to be, they want to know about the amenities. They want to know about where all the best restaurants are. They don't want to just live somewhere where there's a McDonald's or a Taco Bell to choose from. So the way that we're really going to improve the access is to keep trying to invest in the virtual care.
Yeah. Shifting to health equity, Mental health care is difficult for many people to access, but it's particularly difficult for those without insurance, those with low income, those in historically underserved or underaddressed communities. I want to talk about why these groups have a harder time accessing care. Dr. Kumar, can you share your thoughts about this and what Cone Health is doing to improve access?
So I think, from the perspective of making sure that people can get insurance, yes, you can look at that pathway and say, there needs to be parity. It's going to take a long time for that to happen. So how do you as a community come together with healthcare to set up a setup for people who don't have insurance? So care shouldn't be dependent whether you can pay for it or not pay for it. Everyone should be able to have their basic needs, whether it's primary care and behavioral health, met. And that's how we came up with the concept of Guilford Center, which provides behavioral health care with also primary care. So people who are insured, uninsured, everyone has one place to go to make that difference. And like Paula and Barbara said, we've used a lot of technology within our rural setups, including Randolph Hospital. How do you provide these services to people where they are? So adding technology to this center is what's making that difference. And that's what we're trying to achieve. We're relatively new, so it's going to take a while.
Mental health services are federally required to be covered at the same rate as physical health services. Those rules are called Parity Laws. Robin, can you tell us why those rules are important and how they could be improved if they're not ideal right now?
Well, it's, we've had mental health parity laws federally since about 2008, 2009, in North Carolina about the same time as well. And the problem is, so we have parity, but we haven't been able to enforce it. We haven't been able to ensure that we actually have parity in place. And what that means is, in the old days, it meant, we used to have like a $10,000 max for mental health care. And so some of those things have certainly gone away. But there are other kind of insidious sorts of ways that parity is playing out, or lack of parity is playing out. I'd be so bold as to say it's part of why there's shortages of some of the specialties. And I know from a mental health perspective, not only my psychiatric physicians, but all the other mental health professionals, part of those teams, are implicated by the fact that there's not rate parity. There's, people aren't looking at mental health necessarily as being a chronic disease or addictive disease, a chronic that you can't necessarily get cured, that it's more like, a long-term disease like diabetes or something. But there is some hope. And that is, back in December, President Trump signed part of one of the COVID stimulus bills that he put into effect at the end of December, included mental health parity compliance language. And this is a huge win because it has implication, both federally and for states, state parity legislation. And this new law requires all insurers and group health plans to perform parity compliance analysis, and then to submit them to the federal and state regulators on request. And what that means is you have to compare it. You have to say, I'm offering this from a med-surg benefit, and how does this compare to mental health? And so it requires, they must perform the compliance analysis, and they have to provide this comparative analysis to state departments of insurance on request. But the problem is that on the state level, the state departments of insurance is not required to collect an analysis. And they can ask for an insurance company to do a comparative analysis, but they don't have to. In North Carolina, our Department of Insurance did receive a Centers for Medicare and Medicaid, a CMS grant a few years ago to develop parity compliance tools. So North Carolina DOI is in a place where they can teach insurance companies what parity is. They have a checklist, so they can also audit insurance companies to see what parity is, but we don't have state legislation that requires the Department of Insurance to ask them. And we are hoping that our state Department of Insurance will proactively, move forward to get this, to get these analyses done. And it's been kind of exciting to work for the North Carolina Psychiatric Association to work with the North Carolina Healthcare Association on this effort. So we're hoping we might not have to go at this legislatively, but we may have to.
How can the current approach to managing people in crisis be improved? Dr. Kumar, can you tell us a little bit about your urgent care?
So I think it's partnerships which makes it happen. So it was, I would say, about 5 to 6 years of working with the county commissioners, working with our LME, Sandhills, which is how they broke up behavioral health into different sections in the state. And, kind of looking at what were the community needs. So if you're looking at this center, who's going to pay for the cost of it? Just like Robin said, we talk about parity, but there isn't parity. Anyone which has an addiction diagnosis or is an adult who cannot afford health insurance cannot get behavioral health services. So where do you look as a community to come together to make this happen? And then, what's the best location for it? So is it easily accessible for people who do not have transportation? Is there a bus route? Is it next to social services? Because you need to make sure that people who are struggling already financially, emotionally, and really need their social needs met, can you have it located in a place where that's easily accessible too? So it does require a lot of effort, but I feel that, like everyone said, behavioral health has always been, okay, no one really wants to do behavioral health because you don't get paid for it. Or, a social worker, whether it's a therapist, whether it's a caseworker. So if you're going to change that whole outlook, you're going to have to come in together as a community and find a solution for it. So this Guilford County Behavioral Health, it's nice to think about these things, but it's also important to make sure that the group comes together and you have documentation that fragmentation of behavioral health. Like Robin said, you had a mental health center in the community years ago and it went away. People knew the Guilford Center. So, how do you change that? And of course, we're taking a whole circle and coming back. But at this time, also adding the primary care piece, which is important, because behavioral health patients die 15, 20 years earlier if you have a diagnosis of schizophrenia. Your risk of suicide is 20 times higher than the general population. So what are all those other pieces to keep people stable? And then look at our jails and prison systems. Why are people with mental health sitting there instead of getting the help they need? So if you're going to do all those pieces, you need a setup which has all those requirements for making sure you're successful. We've been open 3 months. We've seen about 3,000 patients. We have not only an urgent care, so I think that's the first thing. Behavioral health the Guilford Center has, of course, an urgent care. It has a 16-bedded facility crisis center where, people can stay for 2 to 3 days. They're detoxing. We'll do the medical piece, IV infusion, meet their medical needs, and then a 16-bedded center for children and adolescents. And then on the second floor, an outpatient center, which has open access for people to get services. And the most important piece, which I feel is really important for people in mental health for recovery, is a peer living room, a place where people themselves have struggled, who are in recovery, can help support people who need that help without the stigma which is attached to it. So, I'm a little crazily passionate about it, but I feel that to change all these things, you do have to have all these partnerships, and health systems need to get involved in the business of behavioral health.
Absolutely. Barbara Ann, can you talk about the UNC WakeBrook Crisis Diversion Center?
Yeah, thank you so much for the opportunity and support everything that Dr. Kumar just said. So WakeBrook is located in Raleigh, and it does serve as a crisis diversion center. And, the evidence is there. It's in the literature, but even at WakeBrook, we have published multiple times, our quality metrics. We do have primary medical care integrated with behavioral health care. And Dr. Kumar just said in 3 months, they've already seen over 3,000 people. Like, that's so great. But the scary piece to me is like, if that center didn't exist, those folks would either just be sitting in an emergency room somewhere and, or even worse, not getting any, help or services at all. So at WakeBrook, it's integrated care and we have the great results. And we are always at capacity and we are always fighting to keep the doors open, but it's a growing population. North Carolina is a great state and people are moving here. So we need to be able to replicate these centers in more counties.
Absolutely. Let's talk a little bit more about some of the innovative solutions for improving access to mental health care, just along those lines where we're clearly seeing that we need more resources. Telehealth and virtual visits have grown a lot during the pandemic, especially for mental health care. Gary, can you touch upon how telehealth has helped chamber members and their employees better access care?
I think from two different perspectives. First, as a staff of about 28 here, we're going to be incorporating a telehealth service for the staff at the NC Chamber based upon the feedback that we receive from our member companies, but also from our employees here. Health IT, telehealth, telemedicine, incredibly important to help people who have different considerations, as we talked about earlier, access care, get triage, talk about things they need to talk about in order to help heal from every direction. As a personal aside, during the pandemic, I was taking care of both of my parents in our home, and having the access to telehealth services really, really important to help them navigate, even though, they're both 89, so they didn't have a computer. I was able to help them through it, which is an opportunity and a challenge. If, the telehealth doesn't help if the person doesn't have access to what was talked about, either whether that be broadband or a computer or someone to help them navigate it. But when you do, and when you have that support, it was incredibly important for my parents to be able to talk about what was going on with a healthcare provider, and in the safety and the comfort of a place where they knew that they weren't going to catch a virus.
Yeah.
Because those folks went through a lot as they were growing up, and they were really scared. So we're hearing a lot about it. We're going to do it for our staff here, not only for them, but as was said earlier, for their families to have access to. So it's critically important. The pandemic showed us and scared us in a lot of ways, but it also revealed opportunities for innovation and probably and likely accelerated those innovations that'll help a lot of folks.
We hope so. Yeah. Can anybody else speak to how you've seen telehealth benefit your patients and communities?
What I'm hearing from psychiatrists is that they've been shocked at how well their patients and how well they have adapted to telehealth, and even the ones who are saying, I would really want to see my patients face to face, but especially during the early days of the crisis, their no-show rates plummeted. Patients came to all of their appointments, which was wonderful. I mean, and it was really wonderful to hear medical leadership at one of the state's major insurance companies saying, isn't that a great thing? The no-show rate has gone down. So that's one of the things that we've seen.
Yeah. And
The other thing, I'm sorry. The other thing my psychiatrists have said is that they really enjoy seeing their patients in their home environment and being able to have that as part of the assessment, especially my child and adolescent psychiatrist, being able to see, the bedrooms and setup and the interactions with their pets. That's just been very robust and enriching for them from a data perspective in caring for their patients.
Yeah, I love that. I think that is a unique opportunity within psychiatry to really have a window into a patient's life. And I agree, that's a very powerful tool. Another way patients can access mental health care is to operate integrated within their regular doctor visits. So how is your system in integrating mental health care into primary care? I know you touched upon that before, Dr. Kumar, but can you tell us about Cone Health's integrated behavioral health program?
So we started this journey way before COVID. It was about 7 years ago. I'm a child psychiatrist. So for me, I think everything starts, when the baby's born. I'm not talking about age 3. So we started a program in our OB clinic where we embedded a behavioral health specialist, so a behavioral health clinician, with the support of a psychiatrist for those pregnant moms who needed maybe anxiety, depression, or substance use disorders, help them with that, link them with services, make sure that they were doing well during their pregnancy. And I think most people know in healthcare, when mom is 6 weeks postpartum, she loses her insurance. So we have another indigent clinic called Community Wellness, which is for adults, and the child goes to our Cone Center for Children. We linked it so everywhere in all these 3 setups, we had an embedded behavioral health specialist and a consultant psychiatrist, and we tracked, it was a one chart for the mom and the baby, where the bonding issues, where they continued other issues, where the developmental delays. That was our first start in our journey for integration. From that and seeing the outcomes and seeing how great it is to be able to provide that support in your community, we started with all our pediatric practices have embedded behavioral health specialists, along with a psychiatrist who's a consultant. And then we've now branched out into our primary care and specialists like cardiology. People who come in for palpitation all the time are calling the office, having it either embedded or virtual. Now, there are patients, some of them, which are comfortable with virtual. They don't want to come into an office. And with COVID, everyone knows it's gotten worse. So kind of, devising what's going to work best for the person and their family and provide that care, whether it's at the PCP's office, whether it's in their house. And we look at their anxiety and depression and call them to see, hey, I see you've been struggling. Do you need more support? That's the kind of way we've done with integration in our healthcare system.
Did you want to touch upon anything about WakeBrook or at Novant? Does anybody else want to weigh in?
We're doing very similar things to what Dr. Kumar is doing at Cone with the embedded therapist and really focusing on subspecialties and recognizing, again, that there is no health care without mental health care, that it is holistic. So we need to be involved in all aspects of care. And we're really working toward that and partnering with outside entities as well, because we know that it's going to take more than just our system to make this successful.
And there are there's exciting research going on out in the world. And in fact, we're very excited that North Carolina Medicaid has adopted one of the new models. It's called the collaborative care model that allows a psychiatrist and a mental health professional to be kind of helping a primary care physician manage patients in that practice. And so the fact that Medicaid is paying for this model is very exciting, and looking for some of the other insurers, because it's the most heavily researched successful integrated care model that's being studied right now. So we're excited about that moving forward in North Carolina.
And Robin, you're right. That's what we started out years ago before the reimbursement started. So you're absolutely right.
Amazing. Fatal opioid overdoses actually increased more than 13% in North Carolina last year. How are your systems tackling addiction and substance use disorders? Barbara Ann, can you tell us more about some of the solutions that you guys are using at UNC?
Yeah, absolutely. Thank you. And part of this too, when we talk about barriers with funding, is that most of the programs that we have are based on grants. So something to just draw attention to, but we've started screening. I mean, that's another piece of the technology we haven't mentioned yet, but with electronic medical records, we can do a lot more screening. And at times I think people shy away from it because you're going to screen and you're going to identify something and then, oh no, what now? So that's why, like, part of the collaborative care model that Robin just mentioned, it's like being able to actually have those on demand, like e-consults, that you can actually get in touch with someone, even if you're an outpatient clinic somewhere or you are in a medical clinic and you identify someone that may be at risk and you don't know what to do, that you can get in contact with a mental health professional to consult with. But and one of the programs that we have that's unique is the Horizons program. And that focuses on moms who are either pregnant or have young children at home and are struggling with addictions. And we actually help to even provide the child care so that they can go to their groups and go to their appointments and get the treatment that they need. So part of it, I think, with this section too, when you talk about addictions, I think some of the mental health stigma is maybe starting to be lifted, but there is still a lot of stigma associated with addictions. So it needs to be talked about, and we have to improve access to medication-assisted treatment. It is evidence-based. It helps promote recovery. It saves lives. And at the WakeBrook campus in Raleigh, we're the only place that is offering medication-assisted treatment to the uninsured that need it. So there's, that's just a drop in the bucket. So there's a long way to go, but there's lots of hope.
Absolutely. Dr. Kumar, Cone Health Collaborative Services for Pregnant Women and Population Health linked with addiction services. I know you sort of alluded to it, but can you expand on that a little bit?
So actually, there was a huge initiative going on to look at a process to see if peer support could help with people who were coming to the ED with addiction services. And one of the big pieces with that, the outcome for that 2-year study was that if you use people who themselves are in recovery to link with that person who shows up in the ER or, with EMS. So we have what's called as North Carolina NC Stop, which includes paramedics in that process. And then they're linked with this peer support specialist who not only sees them if they can see them in the ED or in the field, they follow that patient out in the community and make sure that they can link that patient with services. And, we actually published it. We were able to show a 43% reduction. So all these programs are great, but like Barbara said, funding, you get the funding for a grant. Once the grant's over, there's no funding for the program. So yes, there are a lot of great programs, but how do you get paid for those services? Because otherwise you're writing a grant every year or two to get funding for doing these, even though they have good outcomes.
I think funding has come up many times. We actually have a question from the audience. Taylor from North Carolina Health News is asking, could the panelists speak to the potential impact Medicaid expansion would have on the mental health care landscape and the access to care in North Carolina? Is the North Carolina Chamber supportive of expanding Medicaid?
Yeah, I'll be happy to lean in a little bit on that. And so first of all, we continue to have good discussions with our healthcare community, with the health systems. Health system leadership is involved in our volunteer leadership. So we continue to have discussions. We have no official position on Medicaid expansion with it, but we continue to talk and collaborate with the Healthcare Association, with the Medical Society, and others to talk about what the impacts are. We represent 21 different industry segments and manufacturers to finance companies. So we talk about it, we're having dialogue, but we don't have a consensus as yet, but we're learning. And we are encouraging our local employers to work with the community and work with the professionals in their community to understand what's best for their community. So we're committed to having the dialogue, but we don't have an official position.
Go ahead, Robin.
I was just going to say Medicaid expansion matters. It truly matters. If we can get health care for people in our state and people aren't tethered to jobs because that's the only way that they can keep their health insurance, or the people who have 2 or 3 or 4 part-time jobs and none of them have health insurance, it just really matters. I mean, we're always going to be building crisis services if we can't help people get care and see doctors and see therapists and see their primary care physicians early on in their care. It matters. It really, really matters.
We need to move the problem upstream by having Medicaid. Right now, what we're seeing are those individuals with no insurance using the emergency departments as their primary care and their crisis care for mental health, simply because they have no other options. So we've put them in that place, and it's not optimal. In fact, it can be harmful at many times. So Medicaid, as Robin said, is critical for our state.
And we know, Paula, I mean, when people end up in the emergency room, that is the most expensive level of care in the whole healthcare system. And so if we can treat somebody's addictive disease before they wind up as a GI bleed in the emergency room, that saves everybody money.
Absolutely. Or 8 weeks of endocarditis and needing IV antibiotics.
Absolutely. Paula, actually, while I have you, do you want to talk a little bit about the medication-assisted therapy grant that you have?
Well, Again, it's all predicated on grant dollars, right? So we've applied for a grant. We don't yet have this, but just like the others were talking about being able to start induction with medication-assisted therapy in our emergency departments, and then partnering those non-insured patients into clinics that will provide that service for free for those patients. Because we see a revolving door. People show up to our emergency department. They don't meet criteria for an acute inpatient, but there's no place for them to go to. And so it just that evolution keeps occurring. The other thing we've done, though, that is again more upstream, is working with AI and developing an opioid risk stratification tool that we can start using in our primary care clinics to let people know that you may be at risk for an opioid use disorder. Not saying that you are, but that starts that conversation about prescriptions and about what you need to be looking for. Just like we would look at you have a risk for hypertension. Here are some things that you can do to help mitigate that. And we're just in the beginning discussions of that, but that's been funded by the Duke Endowment.
Promising. Before we jump to the submitted questions, which I really want to get to, I'd like to ask one last question in terms of what employers and communities can do to support mental health care access. Gary, can you talk about the conversation amongst employers and how that's changing when it comes to mental health?
Yeah, a number of things. Groups within the organizations, companies are expanding their HR services. They're expanding their employee assistance programs, making them more readily available, putting them at the front of the policy books in terms of where we need to do, what we need to talk about. The dialogue is clearly changing. Developing groups of employees that speak with each other within the organization, allowing more open discussions about what are the challenges around mental and behavioral health services. As you all know, it can be confidential, or it's good to talk to your peers too, who are experiencing some of the same things. And looking at addiction, as you all know, for example, a lot of the progress that was made, although we needed more on the opioid crisis, was largely wiped out because of the pandemic. And we're kind of starting over again. And companies are aware of that as they look to bring people back to work, as they look to attract people to the jobs that are available, giving the people the support they need, not only for where they are and what they're dealing with, but what may be challenges to them in their future is at the forefront of their discussions, their policies, their benefit structures as we go now into a benefit structure for next year. So there's a lot going on.
Definitely. I know we already touched upon Medicaid expansion and funding for mental health care reform, avoiding criminalizing those in crisis. I know UNC has an employee well-being program. Did you want to touch upon that, Barbara Ann, before we shift to the questions?
Yeah, I did mention it earlier, but just that it's important for these programs to exist. I mean, we're facing so much stress at home, at work, and what the evidence actually shows is that the biggest barrier to accessing support and resources is lack of knowledge. So we have these programs, and I get emails every day of people like, what do I do? What are the resources? And sometimes I think to myself, well, don't you ever look at the screensaver? But we cannot push and advertise that these things are available enough. And again, remove the stigma so people know it's okay to reach out. It's not going to be held against you. It's actually going to be encouraged and supported, and you're going to be cheered for doing it.
I think you segued perfectly into our first question from the audience, which is from Carrie Madsen from Charlotte, asking how can we reduce stigma around mental health so that healthcare providers themselves are willing to seek support? Carrie, did you want to start?
From the provider community, I would really defer to them on how the providers can help each other. I was a pharmacist, but it was a very long time ago with it. So I'll defer to the providers.
Okay.
I think it goes back to what we were talking about early with holistic care, and that this is just part of your health care and it shouldn't be segmented out and be stigmatized. And it sounds like Dr. Kumar has really made some strides in that direction with the work that they've done there. I'd be interested to hear if you've got anything specific for providers at Cone on this topic.
We do, I think everyone has a physician burnout, and it is stressful. But I also think it's really important to make sure that you do it for all employees. And if you're kind of doing it early on, like, Barbara just said, that you're kind of embedding it in primary care. So you go for your wellness visit, or, you have some GI symptoms, some dyspepsia, and you're getting, kind of scanned. And you're also using AI tools to look at, hey, what are your risk factors? What domain do you fall into? Kind of bringing those things up early on. I think if you integrate that whole care, it makes it easier for providers. We ourselves as physicians do, we just talked about substance use disorders. I can tell you that most providers are not comfortable with medication-assisted treatment. So the stigma starts within us. So it's kind of hard to say that you can just get rid of the stigma unless you start educating people and kind of bring it up forefront that, just because you're a physician or a social worker or a counselor or anyone else, a nurse, that, we all have to look at our well-being and see if there are things that we need to do different and get the help we need.
Absolutely. This is definitely an area of passion of mine as well. And I think, having confidential access to resources is definitely something. Having free or affordable resources is definitely a thing, right? I mean, I think some of the biggest barriers for healthcare workers to getting care is some of those questions about time, about money, about confidentiality, and how do you remove those barriers so that they can ask for help early rather than waiting until things are at a breaking point, which is, so often what we see amongst healthcare workers is a lot of self-medication or a lot of denial until it's too late. So definitely important to get in on. Karen Koch from Greenville was asking, how do we get more inpatient beds for children and adolescents in rural communities? Paula, did you want to start with that?
So we touched a bit about this earlier, and that's one of geography and having the providers that would be willing to live in those communities to do the service. The issue is that we do have a certificate of need out there, but we need to find people that are willing to work in those hospitals. In what is it, April of 21 of this year, where the DHHS did stop having the requirement of having an adult distinction versus an adolescent distinction for their certificate of need for psychiatric beds, but it's a matter of also having the funding for those hospitals to open those beds to be able to have enough reimbursement where they break even with that service line. So those things would have to change for those beds to be built.
Yeah. Very specific question from Harriet Denning from I'm going to pronounce this wrong, Fuque Barina. I've always had a problem with that. I've lived in North Carolina for 8 years. I never really say it right. But can Hipaa laws be revised for mental health care patients in an effort to get accurate information from family caregivers? Archana, did you want to weigh in on that?
So, I'm one of those people who believe that families need to be involved in the care, whether you're an adult or child and adolescent. So I do agree that the Hipaa laws need to be changed, but I also think it's important for providers to, and especially psychiatrists, to understand that it's really important to get that information. So, you can always convince a patient to give you consent. That's something I strongly believe in, and that's something we practice here, where we try to get that consent to make sure that the family, even if it's an adult or it could be someone's parent, and the caregivers need to be involved in that care, that we get that consent to be able to provide that care and make sure that we link that person with the right care with their community and their family. Do I think Hipaa needs to go away? I totally agree with that. But then I'm a physician. So for me, in psychiatry, this is a huge barrier. I've just learned how to work around it.
Interesting. Glenn Field from Raleigh was asking, what can we do right now to improve children's mental health care and children's mental health in general in North Carolina?
I would love to say one of the ways to get children to improve children's mental health is to make sure the parents have mental health care and mental health insurance. I think that's one of the most important things. And we've already talked about the need to build services upstream rather than always at the critical point, the crisis point. But I think getting parents help is going to be helping the kids. That's just my opinion.
Absolutely.
And one of the other things is that the American Academy of Pediatrics in 2009 developed competencies for pediatricians that focus specifically on mental health. So if you have a pediatrician out there that is newer to their field, they're going to have the skill set to be able to help provide that psychiatric and holistic care for their panel of patients.
That's great news, Paula. I hadn't even heard that myself yet. You know, I wanted to chime in too, though, that outside of like the moving mountains of waiting for legislation changes, which we know, you know, these things don't happen overnight. Like for people that are on this call right now, it's actually talking about it. Suicide is now like the second leading cause of death for children. And that's like just like totally horrific. And people aren't talking about it enough. I mean, if we're all under stress, like think about how the kids are coping with it and dealing with it. You know, and if kids are transitioning back to school right now, that's really hard. They haven't been in these expectations. They haven't been in these environments. That, you know, they're lacking in their social skills. Like there's just so much stress right now. So it's like having the conversation, talking with a kid about suicide is not going to make them do it. It's just opening up a conversation. We need to check in and we need to keep people physically busy too. I'm a mom myself, so, you know, it's not that I think it's just like easy to say and easy to do, but like limiting the screen time, making sure you're spending time together as a family, you're getting physical activity. I mean, these things might seem trivial, but we all know that we're not doing it enough.
I also think that we need to involve the school systems. If you look at New York City, they've done a great job. They're now treating kids in schools. They are having psychiatrists go there. If a child acts out, they're not sending a kid home or, you know, suspending them for 3 days. So what do we need to do different as a community with the school systems to kind of change the stress on children and understand where is that stress coming from? I do agree with Barbara about screen time. I think people have too much of screen time and too much of my space. Families need to have more family time. But a lot of this can be addressed even in the schools and how we are adding to the stress by suspending kids, not looking at the behaviors, what's causing it and what's going on.
Dr. Kumar, you said that so beautifully. We at Novana we have a grant down in New Brunswick where we have embedded therapists in the middle schools of Brunswick County schools with 5 middle schools precisely for that reason. The school counselors can activate our therapists. We see them remotely. We've already been able to prevent the suspension of kids by getting connected to the right resources. It's been incredibly rewarding thus far.
Absolutely. I think those were a lot of really great questions. A lot of people agreeing in the audience with a lot of what you all are saying. That is about all the time that we have. I would love to thank our panelists, Paula Bird, RN, Vice President, Behavioral Health Services, Novant Health, Barbara Ann Bybel, Director, Psychiatry Services, and Vice Chair, Psychiatry Hospital Services and Integration at UNC Health, Robin Huffman, Executive Director, North Carolina Psychiatric Association, Archana Kumar, MD, Medical Director of Behavioral Health Sciences and Program Director of the Psychiatry Residency Program at Cone Health, and Gary J. Salamido, President and CEO of the North Carolina Chamber. I'd also like to thank all of you in the audience. And if your question was not addressed, please send an email to communications@ncha.org. Today's conversation has been recorded and will be available for viewing or listening at nchealthcare.org. So please share with your community. My name is Dr. Mehta. Thank you again for attending, and please join us next time.